So moving on, I've got a power-packed panel, and we are going to be discussing improving care and outcomes across our partnerships, but through that lens of equality, diversity, and inclusion. And we could take this conversation anywhere. We don't have much time. Keep your questions coming in via Slido. And so on the panel with me today, I've got Kahai. She's a respiratory dietitian and Royal Brompton and Harefield Hospital Charity Fellow, and also a Kofoworola Abeni Pratt Fellowship. And she's at Guy's and St. Thomas's. I also have Professor Ian Kessler. He's a Professor of Public Policy and Management at King's Business School, King's College London. And last but by no way least, I've got Dr. Lorraine Gordon. She's a consultant counselling psychologist at South London and Maudsley NHS Trust. And so let's start the conversation. Why are we here? Let's talk about the culture within our organizations, because, you know, I can hear the words of Sir Gordon Messenger from last night talking about if we improve the culture for our staff, if we get that right, if we create that inclusive culture, it will seep into how we care for our patients. So let me come to you first, Rasleen. What are your thoughts on this?
Yeah, so I think first off, we need to define what culture is, and there are lots of different definitions. The one I like to use is by John Amaechi, which is the worst behaviour tolerated. So we look at the environment and what behaviour we're willing to tolerate. I'm particularly looking at this through a disability equity lens. So we know that disabled people are underemployed, they are underpromoted, they are underpaid. And yet, in the first wave of the COVID-19 pandemic, 60% of people who died were disabled. And some of you might say, does it really matter? Do we need to match the population that we serve? Interestingly, I did a talk recently to our Royal Brompton and Harefield Youth Charity Forum, and after the talk we spoke about disability. And one of the feedback was, I've been a patient here for 25 years and I've never heard a clinician talk about disability the way you have. So that just shows how much our patients really need the gap between kind of lived experience as well as clinicians. You might also say, what is indicating this kind of culture? We did this really interesting survey on the Kofoworola Abeni Pratt Fellowship. So there's some interesting data from Minda Harts in the US, which showed that 80% of white women thought that they were allies towards ethnic minority women, but only 20% of ethnic minority women thought that white women were allies towards them. And so we did this survey for AHPs and nurses, and again we found a similar thing. 80% of white AHPs and nurses across GSTT thought that they were allies, and we also asked them to pick a definition of allyship. We gave them 6 different definitions, and we found the most popular definition, and then when we filtered for white AHPs and nurses, the definition changed. And interestingly, not a single ethnic minority person had chosen the most popular definition that white AHPs and nurses had chosen. So there's obviously a misalignment and a disconnect. On a personal level, I would love to be able to roll into work as a clinician and people not think I'm a patient. That's what I would love to see in the future.
Thank you so much, Rasleen, for those reflections. I'm going to come to you, Lorraine, and I suppose as a psychologist thinking about, you know, getting the culture right. But let's look at the converse, the reverse. When the culture isn't right, the impact on our staff's mental health and well-being and their ability to actually do the job that they're employed to do. So what are your reflections on that, Lorraine?
Absolutely, and as we've been hearing, so culture is so key, isn't it, to any organisation, and actually the culture is set often by the leaders, and when you look at our workforce at the moment at the South London and Maudsley NHS Foundation Trust, where I'm based, so we have like 50% of the workforce is from racially minoritized groups, but yet if you look at the leaders in the organisation, say for example bands 8A and above, it's only 37% diverse, which of course, you know, leads to people, when we fill in the staff survey, for example, feeling that they don't have equal opportunities to training, to career progression, and it impacts on staff engagement and all of those things. And as you say, as a psychologist, racism is out there in society, and we have to name it for what it is. But also recently within our organisation, we've been very clearly naming it for what it is. We've been looking at our practices, we've been looking at our policies, we've been reviewing those using a racialised lens. So we've been doing that for our workforce, and we've got a really robust anti-racism action plan for our workforce that runs alongside our overarching strategy, which is around aiming high and changing lives. Because a key thing for us is really to build that culture of trust with our communities. And if we can't get it right for our staff in the first instance, as you're saying, how can we build that confidence within our communities? And as people have said, in South London, the boroughs that we serve are so diverse, and we really want the diversity of the people that we're serving to be reflected throughout the organisation, so at all levels of leadership. But absolutely, so what we found actually in South London and Maudsley is it's improving, but unfortunately, disproportionately, it's usually black and racially minoritised staff who are involved in conduct proceedings. And this is something we've been working on, been quite focused at working on in the last few years in particular. And we've changed our processes, as I say, like, for example, with our interview panels, we've got a diversity and recruitment champions now that we've had for the last sort of 5 years, where if it's for a leadership role, so band 7 and above, then there needs to be a diverse member on the panel who's had specialist training to be able to support that process and to ensure that it's equitable. So these are some of the things that we're doing to try to tackle that, because as you say, the impacts of racism, racism can lead to trauma, not just for people who use our services, but also for our staff. And so it's important that we do everything we can, if we're thinking about the mental health and well-being of our communities, that we also protect the well-being of our colleagues.
Thank you so much, Lorraine. Professor Kessler, I'm going to come to you. And I keep referring to the annual lecture last night. But one of the things the Golden Messenger talked about was around how we could learn from some of the processes in the military and apply them within the NHS. And so thinking about line management, leaders, preparing those leaders to actually lead with empathy and care within the organisation. So it'd be great to have your reflections on what we can do to build a more equitable talent pipeline within our organisation. That's the first reflection I would like you to have. But also the other reflection is, how do we make, the day job is busy, we're here to save lives, but how can we make sure that we're given enough time, especially for our clinicians, to build their capability and capacity around leading the people within the organisation?
Yeah, I mean, the first question on the talent pipeline, when it comes to equality, diversity, inclusion, we need to be clear what that talent looks like coming from the community, and how it can get access to the NHS workforce and trust workforce. I mean, my experience has been with 2 projects that I've been working with, mainly with NHS England and one with the former Health Education England. The former project with NHS England was about inclusion in relation to people with lived experience of homelessness. And a small pilot project was set up involving trusts, one from each region of NHS England, to try and bring in people with lived experience of homelessness. And it was an interesting project which ran for a year with some success in finding jobs. And these were jobs which were healthcare support worker roles. So these are roles with limited entry requirements where people from the community could come in relatively straightforwardly without the need for high levels of formal qualification. The second project I was involved in was in relation to, I don't know if this is running within the Trust and King's Health Partners, which is Project Search and Project Choice, which are 2 supported employment projects which are designed to provide a year of supported employment for young people with disabilities. And again, those are schemes which are real-life ways of bringing people into the organisation. And when it comes to the question of culture, there's an issue. Culture, by definition, is difficult to change. I mean, by definition, it's ingrained values and norms and behaviours. It's very difficult to change. And in the case of both of those projects, it was quite clear that the trusts were engaged in those projects to try and change culture by bringing in people from the community, a more inclusive, diverse approach. And there was a sense amongst these trusts that you had to take a leap of imagination. You had to make these things happen so that people within the trust got real experience of a more diverse and inclusive workforce. And I think, to your point about pipeline, I think one of the major challenges to both those projects is their sustainability. So it's all very well getting people in for a short period of time, but how do you keep them in the workforce, support them, and as you're implying, get that kind of leadership from key line managers in terms of protecting and supporting and continuing with these initiatives.
Thank you. And thank you to everyone online who's been posting their questions on Slido. I'm going to come to this question first. So following Lorraine's point, how can trusts and organisations best support and empower staff to speak out against examples and experiences where culture hasn't been adhered to or where we haven't had the right culture? And I suppose that question I'll pose to all the members of the panel. You know, what can we do to ensure that our staff feel comfortable and confident to speak? And I'll come to you first, Lorraine, and then I'll come to you, Dr. Kessler, second.
Absolutely, I don't mind responding to that. So fortunately for us, over the last 4 years or so, we've had a real focus on creating spaces, safe spaces, psychologically safe spaces for people to speak out. Unfortunately, it comes on the back of the brutal murder of George Floyd, some of that in the US, and of course the resurgence in the Black Lives Matter movement. And we created, largely led by our EDI lead in the organisational development department, those safe spaces. And we've also done anti-racism training and being an ally training, looking at leaders and management training as well, to be able to equip people to start having some of those historically conversations that people would have avoided and would have been seen as difficult. So really important to have those safe spaces and to be able to facilitate those conversations. I think that's been quite key.
Thank you. Professor Kessler.
Meaningful voice channels are quite important. I mean, my background is traditional industrial relations, and I'm going to mention the trade union word. But I think staff who are subjected to bullying and harassment on any ground need a person they can go to and trust, and not necessarily feel they have to put their own heads above the parapet to raise those issues. So it's not only safe places, it's safe people as well. And I think, although trade unions are a bit old-fashioned, although everybody's going on strike, although they're a bit old-fashioned, the role of a trade union as somebody employed not by the trust, but by the trade union, as an independent person who can raise grievances and raise concerns on their behalf with that individual not feeling vulnerable as a consequence, I think is quite an effective way. And trade unions, in terms of workplace involvement and representation, are very important. We hear a lot about national trade union officers and officials, but it's about union representation at the workplace as an independent, trusted voice for the employee to go to if they face the bullying and harassment that's raised.
Thank you. I'm going to bring you in a minute, Rasleen, on the same point. And I really do like the fact, Professor Kessler, that you mentioned the trade unions. Alongside the trade unions within organisations, we know we have employee network groups, staff networks, employee resource groups, or whatever you might call them. And they're two distinct, they play two distinct roles within the organisation. Like you, I was a trade union rep for at least a decade. of my working life. And I think it's really important to actually say sometimes people might not feel comfortable speaking out directly. So having a trade union to support them is really great, but also having employee network groups. So I'm going to come to you, Rasleen, on employee network groups. You know, how important are these groups within our organisations?
Yeah, so I think the first thing to say is that it can be really, really challenging to speak out. Again, going back to kind of disability equity, a lot of disabled people are worried about losing their jobs. They're already at far greater risk of poverty than non-disabled staff. So it's really important that we acknowledge the context that this is in. I'm the Disability Network Chair at Royal Brompton and Harefield hospitals. And I think it's great. We've made huge traction over the past couple of years. It's so important that we have a safe space and places for people to attend. They can also speak to kind of, like you said, trade union, freedom speak up guardians. Whoever you feel safe to speak up to is the most important place to go. But staff networks are lovely because they are run by the people who are working within the organisation, and they often usually have an executive sponsor as well, and that's someone of the exec team who takes a real interest and passion. They don't have to do that job, they're choosing to be an exec sponsor, so I think it's important just to mention that there are senior links, and so the hope is that a staff network can take it really seriously and have good links to escalate up if necessary.
Thank you. And one thing that I will also raise is, as an HR professional myself, when people do raise things, we must ensure that we are very robust in our response and we follow through and we investigate independently but adequately. I'm going to move on to a question here, and this is about LGBTQ plus the community here. And thank you for the person who has raised this question. And it says, despite our large LGBTQ plus population within our region here in Southeast London, it shows workforce surveys show that LGBTQ plus staff have some of the poorest experience and lowest retention. And this is combined with the anti-trans rhetoric in policy and in the media. And so the question that I'll put to the panel is, what can organizations do to improve the outcomes for our LGBTQ plus staff and patients? And a really, really good question. And I think just my reflections on some of this, we have to be kind to people within our community. We might have differences, but at the bottom line for me is that we're all human, and that has to be at the heart of how we treat people and how we speak to people and how we address issues. So I suppose I'm going to come to you first, Lorraine. What are your reflections? What can we do in the organisation to improve the outcomes for our LGBTQ plus communities?
Yeah, really important question, and that inclusivity is so important, isn't it? For everyone to feel that they have a place that they belong to, they feel that they're making a positive contribution to the organisation, because that engagement is so important for productivity and for well-being, as we've heard. And some of the things that we can do, so for example, I was a listening into action trust lead within SLAM, the organisation that I work for, a few years ago, and my responsibility was on engagement with our colleagues and was to make the organisation a great place to work. And we had this idea of extending the Rainbow Champions movement, and for us what that is lanyards that don't just have rainbows on it but have the progressive chevrons on it as well. And then so that came from the LGBTQ network. We were just talking about networks and how important it is to have active networks that also have a voice and are heard within the organisation and supported. And so we spread the idea of Rainbow Champions throughout the organisation, so that people who wear that lanyard, they're safe people to go to approach, for people to be supported, and also for service users to see, actually, I'm represented here. I can approach this person, I can feel safe here. So just coming back to that idea that when our staff feel engaged and have a sense of belonging, that empowers also our service users to take up the offer of care that we're providing to them in the mental health services as well.
Thank you so much. And, as you were speaking, you just reminded me, within King's College Hospital, we launched our trans and binary policy for our patients, because some of the issues that we face, I believe, are sometimes through ignorance. And so it's really important to educate our workforce that interacts with the diverse community that we serve. And so we launched very proudly that policy a couple of weeks ago, and so I'm sure in other organizations within our area we're doing that as well. I'm going to move on to another question, and it's all about training here. How do we go from training people to activating the training and the root cause of some of these issues? So training is one thing. We're being a bit reactive there. There's an issue, let's train people. But how can we address some of the issues that exist within the system around culture at the roots? And yeah, that's if we knew the answer to that, we won't be here today. But you know, we have to act, and this is all about action. I'm going to come to you first, Rasleen. What are your reflections?
Yeah, so I have a little bit of a bugbear with some EDI training. If you start looking in the literature, you find that some EDI training can have negative impacts. So I think the first thing we need to do is look at the evidence base, look at the data, and if we're implementing training, we actually need to really look at the outcomes and look to see what actually happens with that training. There is some evidence to suggest, for example, if you mandate training, that those who are sitting on the fence actually come out more angry and can come out more discriminatory. So please, let's not just think, right, we've got an issue here, let's put training in, because that's just not going to fix everything. For me, it's about changing hearts and minds. In our disability network, we call it changing hearts, lungs and minds, so we're a heart and lung hospital. But one of the things which we've done as a network is I do something called the Wheelchair Challenge, where I take an exec round with me in a wheelchair for 90 minutes. They do my route across Royal Brompton and Harefield. And that's not to simulate disability, that's quite an important point, and that's linked with negative outcomes, but it's to look at how the hospital environment is not accessible. And ever since then, every single exec who's done it at Royal Brompton and Harefield hospitals has now taken on a disability project, whether it's for patients or for staff. And that's because they felt empowered to realise, actually, there's something I can do about this. I'm in charge of changing the environment. And so I think training is one thing, but I think we need to look more closely around having these conversations with our senior leaders, how we can reach them better, how we can reach our middle managers, and how we can, effectively change their hearts and minds and get them feeling empowered so they can do something today.
Thank you so much. And I think that's really important, the point that you made about sponsors and senior leaders. It doesn't, that any project you take up doesn't have to be just about the workforce. It can be about how we can address some health inequalities that exist within the system. But what is really important as leaders is doing something. It's being active to help change some of the issues we're talking about. Professor Kessler, I wonder whether you have any reflections around this.
Yeah, I mean, training is interesting because, a lot of training outside of apprenticeships, because with the apprenticeship levy, I'm finding a lot of training money gets basically sucked into the apprenticeship fund, and there's very little that's left outside of that. So I think there's an issue about finding the resource to do this. I think obviously induction, well, I would have thought it's very important when it comes to training around EDI issues, because that's the kind of starting point for the introduction to the culture of an organisation. To get it right in terms of what's acceptable behaviour, acceptable attitudes, the values of the trust is very important to establish at an induction level. I think the third point, in terms of your point about who stimulates it, I think there's an interesting issue about where the initiative for EDI training rests. What I found, particularly on my project on lived experience of homelessness, is that project sat with different teams in the different trusts, and it wasn't quite clear, is this a responsibility of our EDI team? Does it sit within the nursing directorate because these people are going to healthcare support roles? So I think EDI is one of those issues where it's not quite clear where responsibility sits in a specialist team or in a kind of service directorate, and as a consequence it can slip between the cracks in terms of whether it happens at all.
Thank you. And, just your last phrase there, albeit I lead inclusion within my organisation, there's this strapline, inclusion starts with I. So anyone under the sound of my voice today, all of you have a personal responsibility going away from this particular segment to think about what can you do? Because it's not the role of the EDI team. We are a small team and we can't do all of this by ourselves. EDI, we have to be instinctively inclusive and we have to weave EDI into the fabric of what we do, whether you're caring for patients, whether you're a finance director, whether you're an HCA member of staff within the organisation. All of us need to go away today and thinking about what one thing can I do to help drive that inclusive culture. I'm going to come to a question here, and I'll start with you, Lorraine. And someone here is asking, well, who are the organisations that are getting this right? What can we learn? What can we learn from other sectors? So, Lorraine, what have you, it might be on a particular issue. Who's getting this right?
Well, I'll talk about what we're doing in our trust, because I'm actually quite proud of what we're doing, particularly in terms of the patient and carer race equality framework. So we're one of 4 national pilot sites kind of leading on that across England. And basically the PCREF, patient and carer race equality framework, came on the back of the Mental Health Act review that Professor Sir Simon Wesley led. And it's really about reducing those health inequalities that we're here to talk about today. And for our service users, particularly in our trust, we focused on the access, experience and outcomes of Black and mixed Black service users and carers. And there is a workforce component to that programme as well. And I'd like to think that we're on a really positive trajectory with this, because sometimes it's not just coming back to the question around training, it's not the what you're learning, but it's the how you're learning it. And leading on this in Southwark, as I do, in terms of PCREF, we've got an emphasis that is a national organisational competency, which is on co-learning. So this means learning with our service users, learning with our carers, and also learning with our community partners. So institutions like Blackfly, for example, that are leaders in the mental health of the Black community. So we sit around and we work together, and we realise that actually it's the part of that process of co-learning that is enabling us, empowering our communities and our staff to see things in new ways, to see ourselves as a resource, and to kind of help unpick some of the really complex issues that we're facing in our organisation. So yeah, proud to say that we're piloting a lot of that work, and that feel that we're progressing with that.
Thank you, Lorraine. Professor Kessler, I'm going to come to you. Project Search, I know across a number of trusts across the country, a lot of people have subscribed to that program. Do you want to share some of the successes that you've come across?
Yeah, I mean, there's some high-profile London hospitals. Royal London and Whipps Cross, as part of Barts, have gone with that. Big Time Imperial has run with that. Quite a few London hospitals. I mean, I think it's at its best that these programs basically provide trust funding. They provide a very secure and worthwhile source of labour, if we're kind of looking at it quite prosaically. Incredible degrees of commitment amongst the young people with disabilities who come into that supported employment, and in many cases the success is where they move from a year of supported employment into a permanent job within the trust, and that is as a mark of success, and the best trusts are succeeding in moving people from supported employment into permanent posts, and that happens quite regularly. A less tangible but another success criteria is your culture point, which is that once people come in from diverse backgrounds, their colleagues become aware and almost shocked, because they have to deal with people with diverse backgrounds, and it's being forced to deal with those situations and that diverse workforce, which actually forces the changes in attitudes and behaviours. So I think it is seen as a way of changing culture, and I think by actually doing it, you do change the culture. You can talk about these things, but until you do them, they're not really going to have that impact. So I think moving people into permanent jobs and changing culture are the success factors, that are criteria and outcomes that you find in those projects.
Thank you. And the last question that I'm going to ask is going to come to you, Rasleen, because it's specifically focused on employee network groups. And this person here talks about the disparities. Some networks get funded, some get time. And, you know, what can we do to make sure that our employee network groups, that our organizations value them, respect them? But there's a lot of work to be done in that job. How can we make sure that there's equity in approach with just even within us in this system?
I seem to get that question quite a bit because it's very topical at the moment, and it's very tricky. So I'm not saying that this is any kind of excuse, because there are some NHS trusts I know in London who give everyone a blank 15 hours a month for like 8 different people in the network. I think in the NHS there are some challenges. I'm a clinician. I'm also a single point of failure clinician. There is no other respiratory dietitian, and so taking time out of my job ultimately means it's a bit of a struggle operationally, and there's this constant tension. I'm not saying that that's right, that we don't have a solution, but I'm just trying to explain again the context that we find ourselves in. So I think it is tricky. I think the things that everyone can keep doing is speaking to the executive team, speaking to their executive sponsor, logging their time, trying to find, again, the impact of what you're doing. And also, I think something which is really important is also publishing the impact of what you're doing. We do an impact report every year now. We've put some of our project work into the North West London Symposium as a poster. So it's really important that the organisation can see the impact, because once they can see the impact, I think they're more likely to invest into you. We started off with our networks as £0 as a budget, and we've went from £1,000 to £5,000 because people can see the impact of the work we're doing. So impact, impact, impact. Keep sharing it. Keep talking about it, put it on social media, be really proud to do it, and keep speaking with your execs to advocate for that time. And I know that's hard because you're a minoritized staff member yourself, but I think we have to think about it for the future as well, future people who are coming into those roles.
Thank you. And I really do like what you said. Impact, how are you adding value to the organisation? Showcase that. And that, being evidence-based and data-driven, showcase how you are adding value. Until we're at time, and it's been a fantastic conversation, and we could continue this all day. Certainly I can. But I suppose as I begin to wrap up, I go back to my point. We would have wasted the last 30, 40 minutes today if all of us who are listening to this don't take a few actions from there. Culture change doesn't happen by osmosis. It takes all of us to do something amazing and to do something different. So I suppose my charge to everyone today is pick one thing. What are you going to do to advance inclusion within your organization? It might be supporting workforce, or it might be towards tackling health inequalities that exist. But whatever you do, please leave here today and do something. Let's show our appreciation to our panel. They've been absolutely brilliant.